Hi everyone, my name is Stephen Miranda from the University of Pennsylvania, and I'd like to thank you for giving me the opportunity to share our work here today. The goal of this project was to characterize practice patterns in serious illness communication at our institution to target quality improvement efforts for glioblastoma patients. What is serious illness communication? This is communication about goals, prognosis, end-of-life preferences, and preferences for life-sustaining treatments. High-quality communication is known to improve outcomes for cancer patients by facilitating goal-concordant care, improving quality of life, and leading to earlier hospice referral. However, for glioblastoma patients specifically, the literature suggests that these conversations may be happening late and may fail to elicit patient priorities before the onset of cognitive impairment. Given the grim prognosis for these patients, it's definitely worthwhile to improve these practices and ensure that these patients get the right care at the right time as often as possible. So how do we assess ongoing practices at our institution? We did this by chart review and qualitative interviewing. First, we performed a chart review of 240 patients who died over a 2-year period, applying a keyword-based rubric from the literature to identify and rate any notes documenting a serious illness conversation, containing at least one of the 4 domains that I previously specified. We also interviewed 5 clinicians across disciplines that care for glioblastoma patients and asked them about barriers and facilitators to high-quality communication. So what did we find? Firstly, based on chart review, these conversations were occurring early, they were highly prevalent, and seemed to be of high quality. The median timing of first conversation was 360 days before death, almost a full year, which is much earlier than is reported in the literature. 96% of patients had at least one documented conversation, with a median of 4 per patient. Approximately 90% of patients had 2 out of the 4 domains represented, goals and prognosis, and a majority had some documentation of all 4 domains. However, despite the success by chart review, these findings were not associated with any clinical outcomes of interest, including hospice enrollment or inpatient depth. Our qualitative interviews may provide some explanations as to why this is the case, suggesting that chart review metrics don't tell the whole story. Some of our interviewees reported that conversations were still not occurring early enough, and when they did occur, they provided little anticipatory guidance about functional prognosis. They reported that specialists tended to remain siloed, neglecting the bigger picture, and overall they characterized these conversations as reactive to sentinel events, such as recurrences or readmissions, rather than proactively eliciting goals and values. So why are these findings important and what can we learn? Well, in transitioning or considering transitioning to value-based models, our study shows that clinical notes may actually be a misleading tool for measuring success in the care of glioblastoma patients. For instance, timing of the first note may not tell the whole story, and in this case, it might actually obscure the fact that follow-up conversations are needed over time to ensure high-quality care. More nuanced approaches, including natural language processing, may be required to assess patient trajectories on an individualized basis, and this is something we're actively working on. Also, in terms of quality improvement strategies, our study demonstrates that a blanket approach may not be successful for all disease types, and in fact a targeted intervention may be needed based on the population of interest. For instance, our institution is currently implementing a communication intervention for all cancer patients, called the Serious Illness Care Program, developed by Ariadne Labs in Boston. To improve uptake in neuro-oncology, we incorporated the feedback from our interviewees to tailor this for glioblastoma patients. In doing so, we developed a parallel pathway for serious illness communication, so that all patients will have at least one SIC visit with a trained palliative care clinician, usually an advanced practice provider. We hypothesized that by doing this will improve not only serious illness communication metrics, but also patient experience and patient outcomes, while easing time constraints and burnout for oncology clinicians. Thank you for your attention and for your interest, and for allowing us to share our work here today.